Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
My name is Haley Ellis. I'm a medical oncologist at Mass General Cancer Center in Boston, and I'm very excited to speak with you all today about the new developments and future directions in HER2-positive biliary tract cancers. So biliary tract cancers are rare and aggressive tumors with poor survival outcomes. They encompass a diverse group of cancers, including intrahepatic, perihilar, and distal cholangiocarcinomas, as well as gallbladder cancer. Progress has been made in the first-line treatment setting with the addition of PD-1 and PD-L1 immune checkpoint inhibitors to the backbone of gemcitabine cisplatin chemotherapy. And this has modestly improved outcomes, though the median overall survival is still about 12 to 13 months, and the response rates range from about 20 to 25%. In the second-line setting, the prognosis becomes even more challenging. Regimens like FOLFOX have a survival of about 6 months and a response rate of just 5%. So we're making steps forward, but this still highlights that there's really a need for further treatment advancements. What makes biliary tract cancers really unique in the GI oncology landscape is its remarkable molecular heterogeneity, which can vary significantly across its anatomic subtypes. And one of these actionable biomarkers is HER2. So the ERB or HER gene family plays a really central role in cell signaling, growth, and survival. This includes 4 members, HER1, 2, 3, and 4, and each receptor has distinct features and functions. Among these, HER2 is a particularly important oncoprotein. It's a well-recognized and established tumor genesis driver in multiple solid tumors, including breast and gastric cancer. And HER2-directed therapies like Trastuzumab have really revolutionized treatment and improved outcomes for patients. And this success in other cancers has really spurred ongoing efforts to extend application of these therapies to other HER2-positive cancers. HER2 alterations exhibit varying frequencies across the different subtypes of biliary tract cancers. We more commonly see HER2 positivity in gallbladder cancer compared to cholangiocarcinoma. And HER2 overexpression or amplification is more commonly seen in HER2 positive cases of biliary tract cancer, while mutations in the HER2 gene itself are relatively rare. The prevalence of HER2 positivity does differ by the anatomic subtype. So we see these in approximately 15 to 35% of gallbladder cancers, 15 to 20% of extrahepatic cholangiocarcinoma, and about 5% of intrahepatic cholangio. So with better understanding of HER2 biology over recent years, the landscape of HER2-targeted treatments in biliary tract cancers has really exploded in recent years, and we'll go over some of the key clinical trials and therapies briefly. So in the chemo-refractory setting, various HER2-targeted combinations have been investigated. So regimens like pertuzumab, trastuzumab, tucatinib, trastuzumab, and trastuzumab with FOLFOX have demonstrated response rates ranging from about 25 to 47%. And these studies have reported median progression-free survival on the order of 4 to 5 months, with median overall survival of 11 to 16 months. There was a study in actually the first-line setting looking at the combination of gemcitabine and cisplatin with trastuzumab, and this has shown really promising efficacy with quite high response rates when we compare it to historical controls. Of course, we can't cross compare these trials, and these are small, though it's still important that we continue to do and evaluate these biomarker-driven studies, even in rare cancers, to help advance the fields. The safety profile of these agents does depend a bit on the drug itself, but we see everything from LFT abnormalities, some cardiotoxicity, mostly which is seen as reduced ejection fraction, You can see some chemo-related side effects here, like cytopenias, peripheral neuropathy, and fatigue, with regimens that include FOLFOX and gemcitabine cisplatin. One of the more recent HER2-targeted agents that's become available for use in biliary tract cancers is Trastuzumab deruxtecan, also known as TDXD. This is an antibody-drug conjugate which combines Trastuzumab, a monoclonal antibody that's targeting HER2, with a potent topoisomerase I inhibitor payload. And this payload is linked to Trastuzumab through a stable, tumor-selective cleavable linker, and this allows targeted delivery of the cytotoxic agent directly to HER2-expressing cancer cells. And the design of this therapy offers several potential advantages. First being that this topoisomerase payload is highly potent and has a short systemic half-life. The cleavable linker ensures that the cytotoxic agent is released predominantly within the tumor microenvironment itself. And third, TDXD does have this, quote, bystander effect, meaning that once the payload is released, it can still diffuse into neighboring cancer cells, including those with either low or heterogeneous HER2 expression. And this is particularly relevant in biliary cancers where HER2 expression may not always be uniformly high across all tumor cells. The HERB study was a phase 2 clinical trial conducted in Japan of TDXD in patients with HER2-positive biliary tract cancers. TDXD showed a response rate of about 36% in HER2-positive patients, which was in this case defined as IHC 3+ or IHC 2+ and FISH positive, and we'll discuss more about this in upcoming slides. And this was in contrast to a 12% response rate in HER2 low, which was IHC 0, 1+, or 2+ and FISH negative. Regarding the safety of TDXD, the toxicity profile is really in many ways quite chemo-like, which is driven by the topoisomerase payload. So common adverse events we see with TDXD include primarily hematologic toxicities. And additionally, another important adverse event that we monitor very closely for is interstitial lung disease. In the HERB study, this was seen in 25% of patients. So this is a really important toxicity to monitor for. Another study evaluating TDXD was the Destiny pan-tumor 02 study. This was a phase 2 basket trial looking at advanced solid tumors that had HER2 positivity, including a cohort with biliary tract cancers. These were patients who had progressed on prior treatments, and this could have included prior HER2 targeted therapies. And in this trial, HER2 positivity was defined again as IHC 3+ or 2+ and FISH positive. Notably, all the confirmed responses were seen in patients who had central HER2 IHC score of 3+. And among these patients, the confirmed response rate was 56%, with a median duration of response of nearly 9 months. The median PFS was 7 months, and the median overall survival was 12 months. In this study, there weren't any responses seen in patients who had HER2 IHC scores of 2+ or lower. Approximately 40% of patients in this study in the biliary tract cancer cohort had grade 3 treatment-related adverse events, the majority being hematologic toxicities, particularly neutropenia. And additionally, interstitial lung disease or pneumonitis occurred in 17% of patients, primarily presenting as grade 2 events, but notably there was one reported case of a grade 5 event, and we'll discuss how we monitor and manage ILD in these cases. Moving on to our newest agent in the HER2 treatment space in biliary tract cancers is Zanidatamab. This was just FDA approved on November 20th, which is very exciting. Zanidatamab is a biparatopic, bispecific antibody designed to target HER2. And what exactly does that mean? It has the ability to simultaneously bind to 2 distinct and non-overlapping epitopes on the HER2 receptor. So this unique mechanism of action results in multiple different therapeutic effects. It promotes internalization and degradation of HER2. It blocks downstream HER2 signaling, enhances antibody-dependent cellular cytotoxicity, ADCC, and ultimately contributes to slowing tumor growth. There have also been studies that have showed that Zanidatamab induces more potent complement-dependent cytotoxicity, CDC, in HER2-positive tumor cells when comparing to Trastuzumab or Pertuzumab, either alone or in combination. Horizon BTC-01 was a phase 2b open-label clinical trial of Zanidatamab in patients who had unresectable or metastatic HER2-positive biliary tract cancer who had been previously treated. In this case, prior HER2 agents were excluded. And this study included 2 cohorts. Cohort 1 was looking at patients who had tumors that expressed high levels of HER2, and this was defined as IHC 3+ or 2+. And cohort 2 included patients that had tumors characterized as HER2 low, which was IHC 0 or 1+. Zanidatamab was administered every 2 weeks, and to minimize the risk of infusion-related reactions, patients received prophylactic treatment prior to each infusion. In the most recent follow-up of this data at 22 months, patients with HER2-positive disease, again, IHC 3+ and 2+ expression, demonstrated a response rate of 41% and a median duration of response of 15 months. The median overall survival has been shown to be 15.5 months in all HER2-positive patients, and when you look specifically at the IHC 3+ group, the overall survival is 18 months. And so this highlights that there's really meaningful clinical benefits with both sustained and durable responses in selected patients. Zanidatamab has a generally favorable safety profile, with the most common adverse event being diarrhea, and this occurred in nearly 40% of patients across all grades, though only 5% of patients had grade 3 or higher diarrhea. And other notable adverse events associated with Zanidatamab include infusion-related reactions, as well as reduction in ejection fraction. So I want to move on to highlighting a case of HER2-positive biliary tract cancer. So this is a patient, a 55-year-old woman who was diagnosed with advanced gallbladder cancer with metastases involving the liver and peritoneum. She had a good performance status and was started on standard of care first-line gemcitabine, cisplatin, and durvalumab as per the TOPAZ-1 study. She had a nice initial response both clinically and in terms of a decline in her CA19-9 tumor marker. But over the course of many months of treatment, developed some expected progressive cytopenias and fatigue, mostly related to the chemotherapy. And after 8 cycles of the systemic therapy, was found to have multifocal progression. She had a biopsy of a progressive liver lesion, which confirmed the same initial diagnostic biomarker profile, which included HER2 positivity with IHC 3+. So this is really critical in biliary tract cancers, is the importance of comprehensive molecular profiling, and that includes testing for HER2 alterations. The NCCN guidelines recommend HER2 testing for overexpression or amplification in all patients that have unresectable or metastatic biliary tract cancer, which again includes cholangiocarcinoma and gallbladder cancer. I wanted to clarify the distinction between HER2 overexpression and HER2 amplification. These terms are sometimes used interchangeably, but they're not always linked in a one-to-one fashion. Overexpression refers to the elevated presence of the HER2 protein on the surface of the cancer cells, and this is typically assessed by immunohistochemistry, IHC testing. Amplification, on the other hand, refers to an increase in the copies of the HER2 gene itself, and this can be detected through techniques like FISH, fluorescence in situ hybridization, or next-generation sequencing. So HER2 amplification typically leads to an overexpression, but not always, and that's why we'll talk about the value of looking at both these testing strategies. Next-generation sequencing does offer a really comprehensive approach. It can detect both HER2 amplification and HER2 mutations, as well as many other concurrent molecular alterations. And this can nicely be done by either tissue or liquid biopsy, which offers flexibility, particularly in biliary tract cancers where tissue accessibility can often be an issue, particularly in tumors like extrahepatic cholangiocarcinoma and gallbladder cancer. Other important things to note about HER2 testing specifically is that we actually don't have biliary tract cancer specific guidelines or algorithms for testing. There's also significant intra and intratumoral heterogeneity of HER2 across these tumors. But I will note that, while there's sort of pros and cons to NGS and IHC testing is very cheap, fast, and doesn't require much tissue. So currently we're using the HER2 testing algorithm that's used in gastric cancer. And so IHC testing is done, and this can fall into 3 categories. 0 or 1+ are considered negative results. On the opposite end of the spectrum, 3+ is considered a positive result, signifying high levels of HER2 expression. If the result is 2+, this is considered equivocal. And so we would reflex test to do in situ hybridization to confirm the HER2 status, and this can either result as positive or negative, helping to clarify the HER2 status. Certainly, while it's important to note that 2+ FISH positive is indeed technically HER2 positive, the FDA approval labels for HER2 targeted therapies like T-DXd and Zanidatamab are specifically for IHC 3+. So that sort of remains still a critical area for identifying patients who would benefit from these therapies. The NCCN guidelines have really recently been updated in the past few weeks to incorporate the approval of these new agents for patients that have unresectable or metastatic biliary tract cancer. And specifically now we have actually 2 FDA-approved therapies in the second-line setting and beyond for patients that have a HER2 expression, IHC 3+. And this includes T-DXd, which has a tumor-agnostic approval, and Zanidatamab, which has a biliary tract cancer-specific approval. And in addition to these newly approved agents, the NCCN guidelines also recommend combinations like pertuzumab trastuzumab and tucatinib trastuzumab. And there continue to be a growing number of targeted therapies available, which is exciting to provide outcomes, hopefully better outcomes for patients with this challenging cancer type. So going back to our case of the patient with progressive gallbladder cancer, so after many months of treatment with gemcitabine, cisplatin, and durvalumab, this patient has experienced some expected cytopenias, as you can see here, including a low ANC, platelets, and hemoglobin. Despite some of these challenges, she's overall still feeling well. Her performance status is good. Her echocardiogram is normal. So when considering the next step in her treatment plan, we face sort of the difficult question about how do we select the most appropriate therapy given the multiple options available. And it's important to consider not only the efficacy, but the side effect profiles in sort of deciding the best treatment for this patient. And the optimal sequencing of these therapies also remains a huge open question, and we still don't have data to totally guide us here yet. Certainly, in light of these patients' cytopenias, and in considering, potentially avoiding some more cytotoxic therapies that could worsen these cytopenias, newer options like Zanidatamab can be helpful as essentially a chemo break. But again, there's many good therapies available, and we can certainly discuss the pros and cons of all of them. So with Zanidatamab being a new treatment that will be available, we wanted to review some of the practicalities of giving this therapy. So in general, it's well tolerated, but infusion-related reactions do occur, and prophylaxis is recommended with standard pre-medications like acetaminophen, antihistamine, and steroids. I will note that despite Zanidatamab being a bispecific antibody, we don't see sort of typical side effects of bispecifics like cytokine release syndrome. As is the case with most HER2-targeted therapies, patients that get Zanidatamab should have a baseline and regular echoes to assess cardiac function. This is a drug that's given IV every 2 weeks, as long as it's well tolerated or until there's disease progression. And like with all HER2 therapies, there is a risk of embryo-fetal harm. So these are important discussions to have with our patients. Diarrhea is the most common treatment-related adverse event that's seen with Zanidatamab. So for grade 1 and 2 diarrhea, which is defined as 1 to 3 loose stools per day, or grade 2 diarrhea, which is 4 to 6 loose stools per day, patients can typically be monitored while receiving antidiarrheal treatments, and symptom management is really key, and supportive care should be initiated promptly. But in the case of grade 3 diarrhea, which is more than 6 loose stools per day, Zanidatamab should be held until the diarrhea resolves to grade 1 or lower. And once the diarrhea is controlled, Zanidatamab can be resumed with close monitoring for recurrence of symptoms. Shifting gears back to T-DXd, this is a moderately emetogenic agent, so pre-medication with antiemetics is advised. Same parameters apply for cardiac monitoring that apply for other HER2 agents. The dosing for solid tumors outside of gastric cancer for T-DXd is 5.4 milligrams per kilogram every 3 weeks. And as mentioned when we were reviewing some of the studies, one of the primary toxicities we really closely monitor for with T-DXd is interstitial lung disease. And we're really vigilant in screening and monitoring for this toxicity. High resolution CTs play a really critical role in how we monitor for this. And with any signs or symptoms, and that includes things like dyspnea, cough, fever, or any radiographic findings that might suggest the presence of ILD, we promptly engage in a multidisciplinary approach to managing these toxicities, and that's primarily in conjunction with our pulmonology colleagues. And we're quite aggressive in managing ILD. So with grade 1, we're already holding therapy, and we can consider resuming it if the patient remains asymptomatic or if the ILD resolved to grade 0. The mainstay of treatment for ILD is steroids. The dosing regimen is carefully tailored based on the severity of the condition. And we generally taper this therapy over several weeks to ensure safe recovery and to minimize complications. But we're getting much better at recognizing and managing these toxicities in patients. So some key take-home messages. HER2 is a key validated target and driver in biliary tract cancers. Comprehensive testing, and I would argue including both NGS and IHC, is important to identify patients with HER2 alterations who may benefit from HER2 targeted therapies. Selecting the most appropriate therapy should be tailored to the individual patient, and this would be important to consider not only their molecular profile itself of HER2, but their performance status, the side effect profile and efficacy of the drug. We have so many available treatments now, including T-DXd, Zanidatamab, as well as other guideline recommended options. So how we best select and sequence these therapies is an ongoing area of research and discussion. Though, again, important to select the right drug for the right patient. And this is also often done in a multidisciplinary discussion. There's really a large pipeline of new agents that are being studied in HER2-positive biliary tract cancer. And we even have phase 3 studies now looking at the combination of some of these existing drugs with immunotherapy and even being used in the upfront setting in metastatic biliary tract cancers, which we don't yet have approvals for other targeted therapies and biomarkers in biliary cancers. So this is certainly a very exciting time for our patients and has really brought a lot of hope to patients with HER2 biliary cancers. And certainly we expect this area to continue to flourish over the coming years. Thank you so much. So some of the questions that are coming into the group include, how can we sequence these HER2 targeted therapies? This is a great question, and the short of it is that I don't have a definitive answer. Again, certainly the toxicity profiles of these agents can be very different. For example, T-DXd, we think of more chemo side effects, primarily cytopenias, interstitial lung disease. Zanidatamab, we see things more like infusion-related reactions and diarrhea. But certainly the efficacy of all these treatments is really promising. I think what will be really helpful, and there's data already coming out based on some of these HER2-directed studies about what are the resistance mechanisms to some of these therapies. So we know that there are upfront concurrent alterations with HER2 as well as acquired alterations that might suggest that patients may benefit more or less from certain treatment strategies. Again, this is still a really huge ongoing area of discussion, and I think remains the big unanswered question in this space. Are there any reports of ICANS with Zanidatamab? So far, there haven't been reports. Again, though it has that sort of bispecific label and mechanism of action, we haven't seen those sort of typical bispecific side effects. Next question is, due to the heterogeneity of HER2 expression, is there an advantage to performing NGS testing by liquid biopsy? I think it's really important, and oftentimes I think we try and pair tissue and liquid biopsy testing to achieve exactly that. Certainly liquid biopsies can be really helpful to try and capture the the spatial and temporal heterogeneity of these tumors and can be really quite minimally invasive. So for patients that do have ctDNA that's detectable, I think it's really helpful to be able to use liquid biopsies, particularly in the setting where tumors like extrahepatic cholangio and gallbladder cancer, where we see higher frequencies of HER2, actually accessing tissue can sometimes be quite challenging. If NGS detects a HER2 mutation, do you still need to confirm overexpression with IHC before giving the HER2 targeted drug, since not all mutations lead to overexpression? So yes, I do think that testing for both IHC and NGS is important. NGS can report amplification of the HER2 gene itself. But again, in some cases, that doesn't always mean that HER2 is indeed overexpressed at the protein level. There are limited commercial NGS platforms that will also concurrently report and test IHC from tumor tissue samples. But for NGS platforms that don't do that, I think working very closely with our pathology colleagues to make IHC testing more routine for patients that have biliary tract cancers is very important. Again, IHC is relatively inexpensive and fast and requires very limited tissue. So of course, in biliary tract cancers, we're very cognizant of the fact that we have limited tissue available most of the time, but I do think it's important to validate, and particularly for therapies like TDXD and Zanidatamab, where IHC 3+ is the label, I think it's important to test for. Do you think HER2 targeted therapies may end up moving into the first line at some point in the future? I certainly hope this is the case, and there's an ongoing phase 3 trial currently looking at chemotherapy, Zanidatamab, plus or minus immunotherapy as well. And again, when we think about biomarkers in other tumor types that are known to be really strong oncogenic drivers, we are using targeted therapies in those spaces up front with really good responses. So I hope this will be the case in biliary tract cancers as well. HER2 definitely seems to be a strong oncogenic driver, and I would anticipate that we might see good responses with this, but that's a question being asked currently in a phase 3 study. Would you ever use the Trastuzumab combinations over the newer HER2 targeted therapies? Again, I think this is a great question about the sequencing of therapies, and we see a lot of parallels with other biomarkers in biliary tract cancers where sometimes we wonder, do we use therapies that have sort of higher response rates and broader efficacy up front, or should they be saved for the second line or refractory setting? The short answer is I don't know. Certainly I would use the side effect profile and performance status and labs to help guide if some of these combinations can be helpful. Though certainly we do indeed see good responses with combinations like Trastuzumab, Pertuzumab, and Trastuzumab tucatinib. Are they coming up with HER2 testing guidelines just for biliary tract cancer? And do we think there are differences compared with gastric cancer? Certainly there are ongoing discussions about developing HER2 guidelines specifically for biliary tract cancers, though this isn't yet available, though discussions are ongoing. And I do think there are differences in the biology between gastric cancer and biliary cancer. I think there's some overlap in the sense that the intra and intratumoral heterogeneity that's seen in gastric cancer, unlike breast cancer, for example, we also see that similar phenomenon in biliary tract cancer. But I suspect that there are nuances particularly on the IHC level, how we're defining what is IHC 3+ versus 2+, etc. Perfect. Well, thank you, everyone. And again, this is a really exciting space, and I know we all look forward to seeing what will continue to evolve in the HER2 biliary tract cancer space moving forward.